introduce me? Is that what you're doing? All right, go ahead and do that.
Okay, good morning. So our speaker today is Dr. Educational Grant through OSU Medical Center, Graduate Medical Education. A disclosure statement has been signed and is on file in the Graduate Medical Education office. Thank you everyone for being patient this morning as we had some technical difficulties and we're kind of working the back door and getting this presentation going. Dr. Tyson graduated from the inaugural class of Edward Via College of Osteopathic Medicine in Carolinas campus in 2015. She came to Oklahoma State University for both her pediatric residency and osteopathic ONMM +1 residency. Afterwards, she completed her fellowship in neonatology at the University of Rochester. She finally stopped doing residency and is actually practicing as an assistant professor of pediatrics in the neonatology division. Dr. Tyson researches neonatal outcomes on preterm infants utilizing OMM. The cloud CME activity code for today's grand rounds is 1813. Please welcome, and it's my pleasure to introduce Dr. Angela Tyson. Thank you.
Hello, thank you guys for everything today. Dr. Ty, can you cut your audio? Because that's gonna thank you. Great. Okay, so this presentation, I had done one earlier in November in this last academic year on how to do like an osteopathic research trial, an osteopathic clinical trial, and kind of background and foundations and things you need to do that successfully. And this is an example of one and some outcomes from stuff I have been researching over the past few years. So this is using osteopathic manipulative medicine on preterm infants in the NICU to reduce neuromotor developmental delays. So our study and design background with our purpose, hypothesis, and aims were involving all around the fact that each premature baby is really at risk for neuromotor developmental delays. 1 in 10 babies are born premature each year. Things that we know help developmental delays is skin to skin, breastfeeding, lots of therapies, including occupational and physical therapy. Neonatal touch and massage has good evidence. But neonatal outcomes with osteopathic manipulation and specifically neurodevelopmental outcomes have never been studied. And then there's something called the test of infant motor performance that's pretty important that we understand too. This is a very well-studied, reliable screening tool that is done in the NICU and outpatient. It has fantastic sensitivity and specificity for predicting neuromotor developmental delays, and it can be used in preterm infants. And that's what makes this so special. You guys who are in pediatrics or throughout your training at all, if you've ever heard of the Bayley's assessment, the Bayley's score, that is the most reliable screening tool that has been developed up until the TEMP. And the Bayley's cannot be used until around when the TEMP starts expiring, around a couple of months of age, because you have to have the cooperation of the infant to do so. And whereas the Bayley's does a better job of social and emotional cues and the whole grand scheme of things from a neuromotor developmental test, this one is better. So it's nice because it can be done in the NICU starting around 34 weeks corrected age, despite how young you were at birth, and all the way up until they're about 17 weeks past term equivocal age, like 3 months. So the purpose of our study was to ultimately seek if osteopathic manipulation improved neurodevelopmental outcomes for these preterm infants. And our first step towards trying to look at that hypothesis was to design a randomized blinded control trial of these infants born less than 34 weeks and comparing their risk of neuromotor delays as measured by that test of infant motor performance and infants treated with OMM compared to those who just received standard of care. And obviously our hypothesis is those who get the OMM versus those who only have supportive care are going to have improved scores on this test of infant motor performance. Our primary aim was to determine the difference in the TEMP scores between the infants who received the OMM and those who only received standard of care. And then we have some other secondary aims that we were interested in looking at. Length parameters, such as like their length of stay, how well they grow based on their Z-scores for weight and length and head circumference, and then how many babies we're feeding at discharge orally versus needing a G tube or an NG tube. We are a unit that does discharge babies with NG tubes. Not every unit does. So for us, this was really applicable. So anytime you do a primary hypothesis with a clinical trial, you really need to have some idea of how you're going to come up with your sample size. When you're just doing a pilot study, you can just say, feasibly, I can take 20 patients, or feasibly, I can do this. And that is not really statistically significant. It may give you some idea and some basis for knowing what to do for next steps, but you're not going to be able to do good statistical calculations off of randomly coming up with a sample size. So we had something done called a power calculation. And this is really important, that if you are ever reading data and you are going through trials, if they did not power their primary outcome, your statistics around everything else may not be as significant as the results lead to be. So at 80% power, which is a good power, you can do a higher power than that or a lower power than that. But the higher it goes, the smaller your standard deviation and statistical difference window can be in your outcome. So 80% is a pretty reasonable power. And this looked at a mean difference of 6.5 points on this test of infant motor performance. We were looking for a detectable difference of 6.5 points in differences between the kids who got OMM being higher and the kids who did not. That's a half a standard deviation. Even doing a full standard deviation, is even more, is almost double that, right? Like 12, 13 points difference. We didn't think we would see that, but we thought 6 points was pretty ambitious to aim for in itself. And this was going to be done with a 2 sample t-test with a significance level of 5%. So this all is statistical world for saying these are tight statistics with an extremely high expectation of this outcome. To do that, based on these statistics and everything known about the test of infant motor performance, we needed 126 kids in our study with an aim of 63 kiddos in each group. So the temp for us, we said, was going to be done on babies between 36 and 37 weeks corrected gestational age. And I just told you that it was validated down to 34 weeks. However, 34 weekers are not very cooperative. Neither are 36 weekers, but they're a little more cooperative and have some stamina and life more than a 34 weeker. Also, 34 weekers usually need some kind of intervention, IV fluids, sometimes surfactant, sometimes they're in an isolate still. So we wanted to give our babies just a hot minute to live before we went and tested their neurodevelopmental outcomes, which is why babies are enrolled if they were born less than 34 weeks and they didn't have a temp until 36 to 37 weeks. The temp has really good standard scores for babies in a 2-week block. So like a 34 to a 35 week and 6-dayer has 1 score block for what you would expect babies at various birth ages to that corrected gestational age to be at. And same thing for 36 to 37 weeks. That's the next 2-week block. So that is the window in which these babies needed to be looked at for the test of infant motor performance. So how do we know who's going in what group and who's going to be able to be allowed in this study and who not? So this was really challenging because how do you know this is going to be safe? And so fortunately for me, Italy has some pretty great data on at least how to approach an infant in an isolate and some multi-center randomized trials showing that the length of stay is substantial, which is why this was a secondary outcome in this study, not the primary, because that's already technically been proving, just not in US babies. And so for us, really looking at the safety of this and knowing, were our infants who were micro preemies, were they going to be safe? Did the kids who were bleeding out in their head, or are they safe to get OMM? Who's okay? So we don't know. We took out kids who required any surgical intervention except for PDA ligations. PDA ligations are a rare thing, but done in kids who are typically stable and who have pulmonary edema and bad bronchopulmonary dysplasia and are going down a very bad rabbit hole from a respiratory standpoint if they don't get that PDA ligated. We do thoracotomies in our NICU for this, and we do coiled procedures in our bigger babies. But this is not a procedure that's done as like a Hail Mary, I'm sick as snot, we're going down the drain kind of situation. All the other surgical interventions for NICU babies, typically something went wrong and it went wrong fast, such as neck and people needing bowel surgery or something else really bad. And if it's not a PDA and it's something else that's not emergent, like a shunt for the brain or some kind of neurosurgical intervention, it's done because something's already very wrong with that baby that sets them up for quite a bit of neuromotor developmental delays at baseline compared to just being a premature infant. So that's why that was an exclusion criteria. We had no idea if severe head bleeds, they can linger on in premature infants. Grade 1s and 2s shut down pretty fast, and they shut down fairly quickly. But grade 3 and 4, they really can go on for quite some time and trickle in there and be very devastating. We already know that those kids have very severe neurodevelopmental outcomes, and I wasn't sure if that was a good comparison to the normal group of babies who didn't experience that or life. So otherwise, things that are bad, like neuromuscular diseases, babies that have hypoxia at birth and experience HIE for hypoxic ischemic encephalopathy, babies who stroke out, these are no-goes just because their baseline can't be compared to a baby that doesn't have that baseline. And that goes along with genetic and metabolic effects, including all of our congenital heart disease kids and our diaphragmatic hernia kids. We get a lot of those. And then if they can't speak English, if parents were unable to speak English, God knows I barely speak English. So, I surely can't consent in another language. So that was an exclusion criteria as well. Otherwise, I did not care how early they were born. Now, at the time when this study was designed, we did not resuscitate 22-weekers. We now do. 22-weekers were thus not included. Had we had done that at the time this was started, they would have been included. And we go all the way up till 33 and 6 weeks of gestational age at birth. And the only reason for this is just to give some time to do OMM and have some kind of intervention on these kids before they need to go and get their test of infant motor performance 2 weeks later. Okay. How to start OMM and when to start it. Now, they can be born as early as they want, but when to actually do this is a whole nother ball game. So how do you know when it's safe to do OMM and at what age of a premature infant? We had no clue. And the Italian data goes back and we look, and everybody is around 28 weeks, correct, the gestational age. Some studies do 26, most do towards the 30s. But there's really no criteria to say why. So looking at other therapy world data, like physical therapy, occupational therapy, and massage therapy, we had already designed a criteria in our NICU for when infants could receive neonatal touch and massage by a nurse or a therapist or a parent. And this was our criteria. They had to be no longer acutely ill, medically stable. And what I mean by acutely ill is pressors, unstable, circling the drain, active interventions. I do not consider a kid on a high frequency ventilation or mechanically ventilated acutely ill. Sometimes our babies are intubated like that for months. That does not make them unstable or medically ill. Means they're just premature and they need that support. So as long as things are riding the course, that did not count towards medically unstable. They have to be able to awaken spontaneously and remain awake after a stimulus ceases. So these are the kids who are getting cares and diaper changes, and they don't try to have a bradycardia event or an apnea event or a DSAT event and try to go see Jesus. They keep it together and they don't try to die. That's when they're having this autonomic stability. And can they stay quiet, alert for at least 5 to 10 minutes after being stimulated? So not only do they have to tolerate care, but can they be okay after care? Do they notice their environment? Are they starting to track things with their eyes? Do they notice you in the room? Are they starting to seek out any kind of social interaction? And can they maintain that physiological stability in response to care? So believe it or not, intubated kids can do all of these things by the time they reach around 27 or 28 weeks corrected gestational age. And sometimes they were just so tiny that they weren't ready to be extubated yet. So I did include intubated kiddos if they were a chronically intubated situation. This all, in theory, has this awakening period around 28 weeks. So that is where the 28 weeks criteria came from. And then that's when you can start OMM in theory. That was our test here. But when are we going to stop an encounter if we're going to do some OMM on babies? So if any of these events lasted for more than 15 seconds, this was a cutoff for us. So I'll get through exactly how I approached each and every encounter for an infant in just a second. But these are tight criteria. I mean, if you've ever been in a NICU or you've been around a premature baby, these suckers scream at you and they will vomit all the time if they don't like how they are touched. And they arch and they kind of get intermittently tachypnic and desatty. And all of these are signs of stress. There are numerous and countless studies that tell us that stressful situations in premature infants create pain, it creates a negative experience, and it creates potentially long-term inflammatory lasting effects that is literally the opposite of the goal of OMM. It is to bring a state of calm, neutralization, calming both the sympathetic and parasympathetic tones, and to try to bring everything back centered for that baby where they are not in a stress situation. How long a baby was going to tolerate OMM or do that and be okay was completely unknown, especially in a premature infant, despite the Italian data. So this was our starting point. So then how do you know how to randomize? So the statistics people help you with this when you do this, but most neonatal studies are done off of two kinds of situations. Either they are looking at babies who were at a certain weight or at a certain age. And when you talk about neurodevelopmental outcomes, almost all things are related back, if you want to lump them into a category of risk factors based on how early you were born or how tiny you were at birth. So you can't usually stratify for both. In our situation, we chose birth age alone. So our 23 and 24 weekers are in a stratum all by themselves. And they are our very few babies born at this gestational age that meet our inclusion criteria with an 18% chance of survival globally. Our survival rate for this population is about 89%. The risk of neuromotor developmental delays in those who survive nationally is over 70%. Ours is less than 50, right around under 50. So there were going to be some babies in this group that were not acute enough or stable enough that without these risk factors that I knew were going to qualify for our study. So we did include them, but they were a small little stratum all by themselves because they're an exceptionally small baby group. Now, your next chunk of real small babies that typically do pretty much better in life as an overall picture are these 25 to 27 weekers, right up to 28 weeks. These are still small babies. They still require head protocols. They still want to, get their heads to bleed real easily. They still require ventilation. They all need surfactant. These are still a high risk population, but their survival and outcomes are better. So that's why they're in the next group. Then you have your random 28 to 31 weekers, still premature, still risky, most likely to almost certainly survive like a term baby is with adequate interventions and therapies. Risk for those babies become less and less. And then you have your 32 to 33 weeker that really, minus a few respiratory hiccups, should be more of a feeder grower situation. The reason babies were not included older than this is because I wanted to make sure they at least got 1 to 2 encounters visited by me, which we'll go over next on how we do this, before they were discharged and before they got a test of infant motor performance. We had to have some kind of intervention done in order to study them. So that's why we capped off at this age. So what did we do? So all these stratums, they are 1-to-1 stratified. What does that mean? That means that I have a bucket of 4 stacks and I have stratum 1, stratum 2, stratum 3, stratum 4, and I have envelopes piled in all 4 of those stacks. And in those envelopes, it will tell me as I pull patient number 1 out of that pile, patient number 1 out of the next pile, whether or not they are in the treatment group or the control group. And the statistician does that for you. And somebody puts them in an envelope that is not somebody part of the study in the treatment group. Okay. So I pulled an envelope based on which age stratum this baby is born into. And each one of those were randomized equivocally in stacks and piles of 1-to-1. So meaning I got 50% kids randomized into a treatment group and 50% randomized into a control group for each of these stratums. The treatment group babies, they get an osteopathic exam, an OMM, for about 15 minutes. I said 15 to 20 minutes initially. We cut off at 15 minutes every 7 to 10 days. So 7 to 10 days is really a flexibility if something was to happen to me or my schedule. And this is where you design this as a trainee or even in life. You have to be able to do physically and feasibly what you say you're going to be able to do. You know, I do take vacation and come out here to Tulsa and teach you guys every now and then and do some other things in life. And taking a 7-day time block would have been impermissible if I did not have the ability to have a little bit of flexibility around that. Or let's say a baby gets really sick and needs a workup, but they're not actually sick. That gave me a little bit of flexibility to say a week and a half over a week. But typically babies had like a targeted date of OMM. Like every Tuesday I was coming in to see this kiddo, something like that. And we did max out more towards 15 rather than 20 minutes. Now, if they were in the treatment group, I did an exam and I did whatever treatment I thought that baby needed, whether it was, you know, everything was more of an indirect. If it's direct, it's very rare and it's based off of all balancing techniques or myofascial release or cranial. There's no pop and crack and a tiny baby. In the control group, now I had to mimic a very similar situation. What was going to happen? We are very lucky in our NICU that there are curtains right around the baby's bed. So what would happen is only I knew which group these kiddos were going to be in. And every week I would go by and I'd say hello, and we do a full screening exam with the nurse. We'd review all lines, all tubes. Everybody knew what was going to happen. Pulled me in the curtain around the bed. If the babies were in isolate ranges, I'd pop the top. And if they were in the control group, I'd just stare at them for 15 minutes. And if they were in the treatment group, I did my thing, but not a single person except me knew what I was doing behind that curtain. Not the parents, not the nurses, not the team, nobody, not a single one. So this was as blinded could be. Now, outside of the room, a nurse was able to view the monitor for the infant, and they knew the criteria of when to discontinue an encounter, whether it was the control group or the treatment group, no matter what. So if they saw that baby going down, they were having a big event, desatting, bradycardic, and they know 15 seconds, give this woman 15 seconds. And then they'd come on in if they got concerned about the infant at any point. But the nurses also documented what they considered a vital sign changer event. Now, some of those things that discontinued an encounter, they couldn't see, like vomiting or arching. That was up to me. So there is some potential bias from that. But vital signs wise, I guess you could say I had a second verifier that did not know or was biased to what was being done in that room behind that curtain. So parents could stay in the room for these interventions, just behind the curtain. They didn't have to physically leave the environment, which made parents feel much safer that they didn't have to leave the room for their baby, but they were okay almost always to enroll in the study, knowing they didn't have a clue what was being done to their baby, which I did think I was going to experience barriers with. I did not. So this is done every single week for these kiddos, right until they reach 35 and 6 days of life. That is the last date they can get one of these encounters, whether the encounter is treatment or whether the encounter is control, based on how they are randomized. And then I back out. I'm done. Angela's done. And then comes in one of our trained occupational therapists. There were 2 people who had gone through what is considered research level score standardizations for our test of infant motor performance for our group. And these people were highly regulated and knowing that they could score these kids accurately and accurately within a 5% window of error compared to all national people who score for the temp. So these scores are very accurate to be determined as adequate and for these kiddos. They come in between 36 and 37 and 6 days of life. And one time the OT does a temp. If the temp goes poorly, the baby just is not going to cooperate, having a bad day, they do have the ability to come back within a 24-hour window and either finish that temp or trial again. That is considered still one total score. But if they failed after 2 attempts, the baby was out. We couldn't get that test. That only happened twice in the whole study. Okay. Other than this, the occupational therapists, they had no clue what group these babies were in. They just knew they got some kind of intervention or they didn't get an intervention. And the therapists were totally blinded. I was also totally blinded to the temps. I couldn't have access to these scores even midway through the study. I did not get a single score on a baby until every child was discharged from the NICU. With not every child, but that was in the study. So here is just kind of an overall scheme of what happened, just to sum it all up. So they had to be born 23 weeks minimum. They got standard of care until, and I enrolled them and I screened them and I talked to parents, and then we'd wait until they hit 28 weeks minimum and until they met all those stability criteria we talked about. And then once they reached the stability criteria and the age minimum, they got able to be treated and enrolled or not treated and just watched weekly for these encounters. All right. If a baby was born at 28 weeks, somewhere between 28 and 33 and 6 weeks, then they could be enrolled and treated the very next day if they met those criteria and the mom and dad consented and the neonatologist group thought that the baby was able to be enrolled. So there were kids born and I was intervening by 4 hours of life all the time in the older, more stable populations. But if they were born before 28 weeks, they had to wait until they reached that, no matter how stable they were. All right. Then they all got intervened on until they hit 36 weeks, 35 and 6 days. So at 36 and 37 and 6 days, that's when the 10 score was done. And then we just hung tight. Their study criteria was over until they were discharged from the NICU. So just for a grand scheme of what I thought was going to happen versus what actually happened as a fellow. So I had this total time proposal, this beautiful Excel sheet, how I was going to get funding, what I was going to do. And this was my timeline that I had. Well, that was cute. Things happen, right? I broke my leg in fellowship and had to go out on a leave for a couple months. Freaking COVID happened. So that was a huge barrier to progress. So this study took longer than I thought. Fortunately, by the time I knew I was ending my fellowship, I also knew I was staying on as an attending, and we just rolled right along like nothing ever happened from my change in status to fellow to attending. But for the study, it just kept right along going. So we finished recruitment in August of this academic year, and then the study was completed by November. I say that because we had to wait for all the babies I just enrolled to actually be discharged from the NICU. All right, so that's the actual timeline. And then funding. You have to have money to do studies, and nobody's going to give you money for a study unless your outcome is convincing enough to make a substantial difference for the community that you're focused on. So funding for this was not challenging. It did not have high needs. Skills for OMM are the person's hands. So that is your time, my time that is needing to be done. So that is a low cost versus needed, this $100,000 lab equipment or some special technology. I didn't need anything like that. I did need these packets to test the test of inframotor performance, and I did need a therapist, and I did pay those therapists for their time. So my proposed budget was $35 a test. I ended up having enough funding to pay these therapists $50 a test. If they came out twice, they got $250 for that test. So I calculated my cost around 15 grand, give or take. I had already had $5,000 as a fellow given to me. So that knocked me down to less than $10,000 that I needed to ask for. The actual cost of the study ended up being much less than that. We found out we had permission from the company to be able to actually copy the score sheet, so I didn't have to pay for more boxes. And then something else that eliminated my cost is the tip had just become knowledge to our NICU when I designed this study. And parents were so happy to have this test performed that we actually started incorporating it in as part of our small baby initiative for babies automatically born less than 28 weeks. If they were in my study, they were getting this test no matter what, screened as part of standard of care. I did not have to pay for tests that were screened for standard of care. So that reduced my cost for the therapist by far. I was just able to use that information. I also received additional funding as a fellow. I had a $25,000 grant for funding to the majority of that went to the department just for my time there as a fellow, and some went directly to me for funds. I had another internal grant that was a small startup fund as a first-year fellow, and then I received a grant through the American Academy of Osteopathy through the Louisa Burns Osteopathic Research Grant Committee. When you are a fellow, if you get an external grant, you get to skip so many beautiful steps when you graduate from fellowship. You do not need to have a manuscript done yet because some stuff may be still rolling and pending. at the time of graduation. You do not need to do a lot of things in order to apply and sit for graduation and boards. It is a whole process compared to residency. And so getting an external grant was a huge motivating factor for me to not have to do those things, especially considering I was one of these people that rolled right into fellowship and attendinghood and continued this trial on. So that was important. So results, here we go. All right. First slide of every single PowerPoint, every single paper is always this beautiful chart. I hope you guys know what this is. This is your demographics. So you always want to make sure that your groups are balanced, and this is what the statistician needs. So far, all the things that we have looked at, like the rates of NEC, BPD, 5-minute APGAR scores, all of that's not really relevant. The things that are interesting is IVH, I pointed out, because I purposefully did not enroll children who had greater than a grade 3 head bleed, 3 or 4. Only grade 1 and 2s was diagnosed in any subject. And there are slightly lower amounts of kiddos into the treatment group. And I point that out because when we look at this in the end time, it may actually be significant. You know, these kiddos were not treated until 28 weeks, but kids above 28 weeks are still at risk for head bleeds. Head bleeding ultrasounds done are per protocol in our NICU. Sometimes they're done in the first week of life. Sometimes they're done in the first 6 weeks of life. And then sometimes they're not done until closer to discharge. And so it all depends on how stable the baby is and how early they were born. The kids who are at the highest risk factors I had head ultrasound results done before they ever hit that 28-week window. But the 28-weekers are still high. So we're still digging through this, because there is a possible chance that kids that I did not know the head ultrasound results on, or kids that were fresh kids that are still at risk for getting a head bleed, may have less bleeds than the kids who do not have OMM. That would be huge if we could show that. So that's an in progress thing. And then bronchopulmonary dysplasia. This is a bear, man. Things can happen to babies all the time. Head bleeds, heart surgeries, bowels in the wrong place. But if your lungs are shoddy, that is a tough thing. And that is one of the highest risk factors for neurodevelopmental outcomes in the neonatal population, is bronchopulmonary dysplasia. And that is defined as having an oxygen requirement greater than or equal to 36 weeks corrected gestational age. So if these kiddos were still stuck on a cannula or any kind of respiratory support by the time they hit the 10th date, we counted them as BPD. And so there are less children with BPD in the OMM group than there are in the control group, and it is statistically significant. So whether or not we should really count this as the children in the treatment group were potentially healthier versus this could be an outcome is still up for debate. We are still working on that, and we are presenting this data at a national pediatrics conference at the end of this month. And once I get some feedback on that, I'll be able to kind of know where to go for the paper, but it may be a confounder, or it may be an outcome. So the TEMP scores, this is good stuff. So the scores are substantially statistically significant. So they are much higher for the treatment group kiddos than they are for the control group kiddos, with a mean difference of 14.6. So this is real cool, right? If we remember, my power calculation was an 80% power calculation to detect a mean difference of 6.5. That was a half a standard deviation, which was pretty rigorous. This is more than a full standard deviation of a difference. That's a big deal. My p-values for all of these groups are like 0.00001. And the next neat thing is it's not only a mean difference overall, but when you break it down to each stratum that these kids were enrolled 1-to-1 in, the differences between each group are similar, and how it goes up and down, the space between the two is very similar. So that's similar and consistent, which means that it's even more supportive overall of your overall goal and outcome. If you look, the kids at 25 to 20, almost 28 weeks corrected gestational age, their scores are higher overall than the kids who are even older with less risk factors at 32 to 33 weeks. So this was very, very unexpected for our NICU. And when I first looked at this, I thought, oh my gosh, this is so cool. It's probably because these little kiddos get more intervention than the kiddos who are born later. There's not as much time window. You know, some of these kids that were getting treatment starting right at 28 weeks, you know, they were getting 8 and 9 encounters in, versus these 32 and 33 weekers. Sometimes they were only getting a couple. So I thought, well, that's cool. Maybe that'll have something to do with it. And then I looked at the controls and saw the same trend for the controls. So the truth of the matter is our NICU is not so great at feeder growers, is what we've determined. We have a lot of focus on our small baby group, a lot. And those kids are doing better at the same corrected gestational ages than our older kids are. And that's not good for us as a unit. And this drew some quite a bit of attention to the unit when these outcomes came about. We have a wraparound care for our babies born less than 28 weeks automatically, where PT, speech, OT, everybody's involved. All the parents are trained in massage therapy. The older kids who are less risk factors don't get quite that attention, and they do now. So not only did this show some good benefits of OMM, but it brought some highlights to our units to say, hey, we're probably doing a better job with the tinies than we are the kids who aren't as big of risk factors, and we need to be paying attention to them too. So the up and down trend may be more of a reflection of our unit as a whole and the interventions these kids are getting all together than it is all just the OMM. But regardless of what these kids get, they were getting the same things between the treatments and the control groups. So I don't know that we can say that the more interventions you get, the better your scores are. But I do think we can say that the kids who get OMM have substantially higher TEMP scores, meaning they have a much lower risk of neurodevelopmental outcomes. And the TEMP predicts it within the first year of life. Length of stay. This is almost exactly what the Italian data saw. Italian data produces most of their outcomes primarily based off of length of stay. And we got similar stuff. So obviously, the younger you are, it looks like there's more of an effect on your length of stay. This may be more based off of the number of interventions that these kids get. It may not, I can't say anymore. But I can tell you that our mean overall length of stay difference for all the kids all together is 18 days. And even when I take these 23 to 24 weekers out, there's only 6 or 7 kids in that group. Even when I take them out, our mean difference in our length of stay is still like 18, almost like 17 days. It's 17 and some change. It is still substantial. So these few kids, though there's a lot of very big difference in the 23 to 24 weeker groups, there's a super small group there. When we crunched the statistics, we actually ended up combining the stratum 1 and stratum 2 together. And then this is real interesting information just for us DOs to kind of knowing how, you know, looking at how to design this trial was tough, because we didn't have a lot of information on safety, and we knew that kids went home sooner, and studies had been done, and thousands of babies had been looked at in Italy, and they were okay, but really producing good information on when to treat and how long to treat has not been done. This now has. So there are 604 total encounters that we have on all of these babies. So that means I walked into a room and I stood in that room up to a maximum of 15 minutes, 604 times for 126 kids at minimum. And when you look at that, we can see that babies who are tinier, they didn't tolerate treatments up to that 15-minute goal, meaning something happened. They met one of those criteria that said stop and walk out of the room at some point, and they did not last for 15 minutes. But once you get around 33 weeks, everybody tolerates the treatment for 15 minutes. And it doesn't matter whether you're getting treated or you're in the control group, everybody makes it around 15 minutes. It's a rare exception that they don't. But these earlier kiddos, one thing I want to point out is that I walked out of the room just as much for kiddos in the control group as I did the treatment group, meaning that they all lasted around the same time. So it may not be that kids can't tolerate OMM for a certain length of time as much as they're going to just have these events that we walked out of the room for, no matter what group they're in. And that's also shown by the opposite. So instead of looking at the time they tolerated treatment, we went back and looked at the actual events that caused me to walk out of the room. It goes right along with what we expected. Obviously, if I walked out of the room and none of these kiddos made it for a total of 15 minutes in this window, then obviously they all had some kind of event that caused me to walk out. So, but they're the same. Look at this. So it doesn't matter whether they were treated or not. Everybody just evented. And then when you start getting to these older kids around 31 and 32 weeks age, actually it looks like the kids in the control group, I had to walk out of the room more for something happening. I didn't touch these kids. So that means that they were having Brady's and DSATs or vomiting or arching or something's wrong with them that caused me to walk out of the room for it lasting more than 15 seconds, a lot more often than I did when I had my hands on the kids. So not only is this safe for premature babies, but it may actually prevent their events to be less. And these are the reasons why I walked out of the event. So overall, looking at all the groups, in the control group, there were 32% of subjects who had some kind of event that caused me to stop the encounter before 15 minutes. And in the treatment group, only 20% of those kids had some kind of event. And these are the kind of events we typically saw. So almost everybody is desaturating. Everybody's having Brady DSATs. That's the majority of reason in the control group why an encounter was stopped for greater than 15 seconds. But there's true apnea for some of these kiddos. In the control kid, there's not a single kid who went apneic in a treatment group, not one. And there's a lot more vomiting in the kids who are controlled. Well, that makes sense. I did see these kids. I didn't say this, but I did always see them before a care. So they were done up by the nurse. It was their time ready to be seen. I did not go in and disrupt these kiddos between cares to do OMM. It was always done with the time of care, and it was always done before a feed because I did not want to be puked on a regular basis. However, they still puked on me. So this may just be with manipulating of the gut and just straight manipulation. Period, kids may be more vomiting. And then I saw way more arching. We didn't see arching in the control group. So is arching really a problem or is it not? It may not be. It may not be an issue whatsoever. It may just be their little reflexes when their cute little 28, 29 week brains or premature brains that are developing that cause them to arch a little bit more. Arching is a well-known sign of stress though. So this needs a little more information, but it is interesting that the majority of problems were more from vomiting and arching compared to these control kids who really just went down. They had a true event. There's a lot less of that in kids who were treated. So conclusions are OMM used weekly on these preterm infants result in better predicted neurodevelopmental scores, better TEMP scores within the first year of life. That says that their risk of neurodevelopmental delays is significantly less. They go home way sooner. They tolerate these treatments around 15 minutes, no matter how premature they were at birth. By the time they're 33 weeks corrected, they have the maturity to tolerate OMM for up to 15 minutes. And then tolerance of treatments for at least 5 minutes around 28 weeks corrected gestational age, again, despite your birth weight, your age, or anything. So this is some helpful information to start having some guidelines to know when to treat babies, how long to treat them, that it is safe, and that it does help. All right, questions? I don't see anything in the chat wise. Anybody got anything they'd like to ask? Okay, guys, I'll be around the med school all day. If you guys have any questions or you need anything, feel free to reach out. You can reach out by email, but I hope you have a great day.